Welcome to Obstetric Care for Patients with Substance Use Disorder, a lecture sponsored by the Tennessee Initiative for Perinatal Quality Care. I am Dr. Jessica Young, an OBGYN and an addiction medicine specialist, and substance use disorder in pregnancy is the focus of my work. I have no disclosures or conflicts of interest. I have 6 key ideas that we will focus on today. I will be giving a brief overview of opioid use disorder and substance use disorder in pregnancy and its impact on maternal mortality. We're also going to talk about the importance of building a therapeutic alliance with our patients with substance use disorder in order to help them engage in treatment as well as reap the benefits of comprehensive prenatal care. I will spend some time on screening for substance use disorder, what is recommended, and some screening best practices. Next, I will highlight pregnancy management during pregnancy and treatment options for opioid use disorder. I will end by discussing intrapartum and postpartum best practices as well as the needs for the 4th trimester. Why is it important as women's health providers for us to expand our knowledge around substance use disorder? Overall, in the U.S., maternal mortality rates have been rising over the past decade or so, and nationally, overdose is a major contributor to maternal mortality. In fact, maternal mortality ratios doubled from 2018 to 2021. In Tennessee, substance use disorder was one of the top 3 causes for pregnancy-related deaths. One of the recommendations from the 2023 Tennessee Maternal Mortality Report was for providers to refer pregnant and postpartum patients for treatment of substance use disorder, particularly after ER or inpatient admissions. In Tennessee, of pregnancy-related deaths, almost 40% had substance use disorder as a contributing factor, and 36% had mental health conditions that contributed to the mortality event. Overdose is the leading cause of pregnancy-associated but not related mortality in Tennessee. Most of these deaths occur in the late postpartum period, 43 days to 1 year postpartum. 80% of these deaths are deemed preventable. I am always struck by this last statistic. The average age of maternal mortality death for women with substance use disorder was 29. This is an age when women are often building their families and careers. These deaths leave gaping holes in the fabric of family systems and communities. The Tennessee Maternal Mortality Report Committee also found that for deaths when substance use disorder was a contributing factor, 55% of those patients received differential treatment that contributed to their deaths. All of this data I have just described compels me to improve care for pregnant women with substance use disorder, and I hope it speaks to you in the same way. One of the most important things that we can do as obstetric providers is to create safe spaces for our patients that use substances. These are safe spaces for them to seek care. This includes having a trauma-informed approach to all of our care, creating therapeutic alliances, using techniques like motivational interviewing to help engage and support patients in behavior change. To have a trauma-informed approach, we must understand that trauma is common and a history of trauma, childhood or otherwise, impacts how people engage with the medical system. People with trauma are more likely to have substance use disorder, other mental health conditions, suicidal behavior, and a host of other medical conditions. Understanding the role of trauma in these conditions can help us be more compassionate providers. What is a therapeutic alliance? In healthcare, a therapeutic alliance is the partnership between a provider and a patient based on shared goals and an agreement on how to work towards achieving those goals. This levels the playing field and creates a relationship where we as providers are walking alongside patients rather than directing their care from a position of authority. This sort of relationship is particularly helpful when you are working on health issues that require some sort of behavioral change. I imagine many of you have heard of motivational interviewing and may have had some training on motivational interviewing. It is beyond the scope of this presentation to provide an in-depth description or training on motivational interviewing. However, I will say that motivational interviewing has helped me engage with patients more effectively for many health conditions that require some degree of behavior change. Some of the strategies used in motivational interviewing are starting with open-ended questions, incorporating affirmations, so acknowledging behaviors that patients are already doing well. Reflective listening is a technique where we repeat back what we have heard a patient say. An example might be, I hear you saying that you want to quit using substances, but it is difficult because your partner is still using. This gives the patient an opportunity to confirm or to clarify. Lastly, summarizing at the end of the visit and highlighting any action steps the patient has agreed to can be very helpful. Getting naloxone into our communities is an important tool in overdose prevention. Naloxone can be prescribed and is covered by most insurances. Some pharmacies even have programs for distribution of free naloxone kits. If a patient is paying out of pocket for naloxone at a pharmacy without a prescription, it is generally in the $45 to $75 range. Tennessee has regional overdose prevention specialists that can offer free naloxone training and kits for different groups throughout the state. Hopefully, we have identified some ways to make the spaces we care for our patients safer and more welcoming. Next, we will talk about screening for substance use disorder in pregnancy. Why should we be screening for substance use disorder in pregnancy at all? I would argue that pregnancy is a time when many women are seeking help and motivated to make changes in their lives. Also, the American College of Obstetricians and Gynecologists recommends universal screening for substance use disorder during pregnancy, and that routine screening should rely on using validated screening tools. The purpose of screening is to be able to provide a brief intervention and referral to treatment if necessary. Unfortunately, there may be barriers to screening. This may be related to time constraints, not knowing what to do for a positive screen or where to refer. There may also be discomfort with having some of these difficult conversations. There are validated screening tools for substance use in pregnancy. The two most common are the NIDA Quick Screen and the 5Ps Plus. Both are validated and brief screenings that are built into many electronic health records. The 5Ps Plus consists of 5 questions, starting externally to the patient. It asks about parental use of substances, peer and partner use, as well as past problems that the patient has had personally with drugs or alcohol use, and then ends with the present use, past month use of any substance. Any yes to any of these questions is considered a positive screen, and next steps will depend on which questions are positive. The NIDA Quick Screen asks about specific substances used over the past year, as well as the frequency of use. Whichever tool is used, the next step is a brief intervention, which consists of a short conversation where you may get more history, provide targeted education, and assess goals or a motivation to change. Depending on what is learned during that brief intervention, it may be appropriate to refer that patient for treatment. You might wonder, what type of treatment does a patient need? This is going to depend on the substance type they're using, any medical comorbidities, their gestational age. It may also be helpful to enlist help from an addiction medicine or psychiatric colleague if this is unclear. Treatment setting options include outpatient, intensive outpatient programming, which tends to be 9 to 15 hours of programming per week, residential programming, or inpatient hospitalization. There are also longer-term residential programs that may last 3 months up to 2 years or even longer. This is an example of a process map for the implementation of screening, brief intervention, and referral to treatment, otherwise known as SBIRT, at a new OB visit. This will look different depending on the resources in your outpatient setting, but it serves as a good model for conducting screening and triaging for referrals to treatment. This is a process map specific to the 5 Ps plus screening. You can see that for positives to parental, peer, or partner use, it simply requires some brief education about risks of substance use in pregnancy, as well as potential screening for safety. For past and present use, we want to review substance type, severity, and frequency of use. This is where we would recommend urine drug testing to be done with patient consent, as well as making sure that the patient has naloxone for overdose prevention at home. If there is present use and they are not in treatment, we would refer them to a substance use disorder treatment program in our community if we don't have these resources available within our settings. Additionally, if they are in treatment already, this is a great time to get releases of information to allow for communication between the addiction medicine provider and their obstetric providers. What about urine drug testing? It does have a role, just not for screening. In general, urine drug testing should be done when it plays a role in medical decision-making. Urine drug testing is not a screening tool, and it should be only performed with informed consent and in compliance with state laws. It is very important to know the test that is commonly used in your setting. What does it test for? What doesn't it test for? Do positive results get confirmed automatically to confirm if they are true positives? There are many substances that aren't on routine drug panels, including fentanyl, xylazine, ketamine, and many others. Patient education around urine drug testing includes discussing the implications of a positive result. We as providers must understand that there are false positives and false negatives with urine drug testing, and many over-the-counter and prescribed medications that we commonly use in pregnancy can cause false positives on drug tests. Let's say you've conducted screening and determined your patient would benefit from a referral for treatment of substance use disorder in pregnancy. For our pregnant patients with TennCare, each managed care organization has high-risk obstetric case managers that our patients with substance use disorder qualify for. These case managers can be helpful in getting patients any needed referrals. There is also a state website called Find Help Now that stays updated with residential and outpatient treatment programs and can help us know if programs have openings and if they accept pregnant women. I would highly recommend all obstetric practices to have relationships also with their local addiction providers. This includes methadone clinics, buprenorphine programs, as well as residential programs. So what is your screening process for substance use disorder during pregnancy? Does anything need to be changed, added, improved? This is a subject that is really well suited for quality improvement projects so that we can improve the standard of care for all of our patients. Next, I'm going to focus on treatment options for opioid use disorder during pregnancy, as this is one of the most common substances we see in pregnancy and is one that we have the most effective treatment options for. However, I acknowledge that this is not the only substance type that people use during pregnancy. The treatment options for opioid use disorder include medications for opioid use disorder, methadone, buprenorphine, and naltrexone, and medication-assisted withdrawal. Regardless of the care path chosen, psychosocial support and treatment is essential. Methadone is the medication for opioid use disorder that has been used the longest in pregnancy. It has been used in pregnancy since the 1970s, and for years was considered the gold standard of treatment. It is a long-acting opioid agonist and works to prevent withdrawal and cravings because of its long-acting nature. We know that methadone use decreases relapse rates. Some studies have shown that it also increases adherence to prenatal care. For people who are actively misusing opioids, the rate of babies having withdrawal is about 75 to 80%. Those withdrawal syndromes are referred to as neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. For moms on methadone maintenance, the severity of neonatal opioid withdrawal syndrome decreases and the risk of withdrawal decreases to about 50%. A disadvantage of methadone is that patients must enroll at federally licensed methadone clinics, and methadone requires daily witness dosing for a prolonged period of time. This requirement may make methadone less accessible, as not everyone lives in a county that has a methadone clinic or has transportation to get to a methadone clinic. A benefit is that unlike buprenorphine, people do not need to be in withdrawal to start methadone. Generally, initial doses start between 10 to 30 milligrams and are titrated up as needed. These dose titrations depend on withdrawal, relapse, and cravings. It can be helpful to confirm a patient's methadone dose prior to admission to the hospital or during a hospital admission. Methadone should be continued while a patient is inpatient. A reassurance that we can give our patients on methadone is that the dose of methadone does not affect baby's risk of having neonatal opioid withdrawal syndrome or withdrawal. In other words, withdrawal is not dose dependent for methadone. Buprenorphine has been used in pregnancy for the treatment of opioid use disorder for about 20 years now. It is a partial opioid agonist and a partial opioid antagonist. Because of this, it requires that a person starting buprenorphine be in moderate withdrawal from opioids before they get their first dose. If a significant percentage of their opioid receptors are occupied by another opioid, buprenorphine will rapidly displace that opioid from those receptors, but it won't activate it sufficiently, causing them to have withdrawal. This causes what is called precipitated withdrawal, which makes patients feel terrible and could even precipitate uterine contractions. The advantages of buprenorphine in pregnancy are that it is an office-based treatment and doesn't require daily visits to a clinic. It also can be prescribed through telehealth, which makes it more accessible for people in rural areas or with transportation issues. Some studies have suggested that the risk of neonatal opioid withdrawal syndrome is less and potentially causes shorter hospital stays for babies that need treatment for withdrawal. There are newer extended-release formulations of buprenorphine that are starting to be studied in pregnancy. Disadvantages include having to be in moderate withdrawal to get started on buprenorphine, which can make the initiation process uncomfortable and scary for patients. It can be less effective for people using higher doses of opioids, and there are limitations to dosing. Starting someone on buprenorphine when fentanyl is the primary opioid has been a challenge due to increased risk of precipitated withdrawal. The rates of neonatal opioid withdrawal syndrome are about 20 to 45% for babies exposed to buprenorphine, and while those rates are lower than for methadone or for someone actively misusing opioids, it is still important that patients prescribed buprenorphine be educated on the potential for baby to experience withdrawal symptoms. Traditional initiation onto buprenorphine involves people being in moderate withdrawal, so abstaining from opioids for 12 to 24 hours prior to the first dose of buprenorphine. One way that people are monitored for opioid withdrawal syndrome is a score called the Clinical Opioid Withdrawal Scale, or COWS. For someone getting started on buprenorphine, their COWS score should be greater than 12. Buprenorphine can be started in 3 settings. It can be started at home, it can be started in the office, or it could be started in an inpatient or treatment center setting. A home induction involves a patient waiting to have sufficient withdrawal symptoms before administering a test dose of buprenorphine. For patients using fentanyl, often we use very low, what we call microdoses of buprenorphine, and then slowly titrate up. If a patient is started on buprenorphine in the office in an outpatient setting, they should be in moderate withdrawal at that visit. In general, for pregnant women, we recommend inpatient initiation on buprenorphine for people over 24 weeks of pregnancy. Regardless of what treatment pathway a patient chooses, it is important to know how we can treat some of the symptoms of withdrawal. There are several medications that are safe in pregnancy that we can use to alleviate these symptoms. Antihistamines can help with some of the anxiety that comes with withdrawal, and hydroxyzine is a common medication used for that. We also can use anti-inflammatories like acetaminophen to help with muscle pain and aches that we commonly see in a setting where someone is experiencing withdrawal. Many patients in withdrawal will have nausea, so we can use our antiemetics like ondansetron or promethazine. And then an alpha-2 agonist like clonidine can also be helpful for withdrawal symptoms and anxiety associated with withdrawal. Muscle relaxers can also be helpful for aches and pains. A frequently asked question about buprenorphine in pregnancy has to do with two common buprenorphine formulations. Buprenorphine comes as a combo product, which is buprenorphine naloxone together, as well as a mono product, which is plain buprenorphine. I'm going to say the brand names because this is what patients refer to them as, but this is not an endorsement of brand names over generic. Combo product, brand name is Suboxone, and the mono product brand name is Subutex. So for combo product, we do not have any data that there is harm for naloxone in pregnancy, but out of convention, based on the initial studies done on buprenorphine in pregnancy, the recommendation for years has been for pregnant patients to be prescribed buprenorphine alone or the mono product. So there have been more studies associated with the mono product in pregnancy. However, there are benefits to the combo product or buprenorphine naloxone in pregnancy. There can be less diversion and less misuse with the combo product. We also know that it's safe in breastfeeding. And we have some retrospective studies that suggest that the combo product is just as safe as mono product during pregnancy. For mono product, we do have more studies with buprenorphine, plain buprenorphine, and we also know that it is safe in breastfeeding. So we are at a point where we are likely to see as obstetricians patients who are either on the combo product or the mono product, and either way is fine. So what about medically assisted withdrawal? Can we detox patients from opioids during pregnancy? For years, we thought that it was not possible or safe to withdraw someone from opioids during pregnancy without using a maintenance medication like buprenorphine or methadone. What we now know from a few studies is that it is possible to medically assisted withdraw someone from opioids during pregnancy. But the question is it wise? How successful is it? There are some benefits of medication-assisted withdrawal. If it is successful and patients are withdrawn from opioids in a significant time frame prior to delivery, it does reduce the risk of neonatal opioid withdrawal syndrome. Theoretically, it also reduces any potential long-term effects of opioid exposure during pregnancy. In some communities, it may decrease the risk of Child Protective Services involvement. Because there is stigma around medications for opioid use disorder, it may also be more supported by a patient's friends and family. I think it is also important to acknowledge that some patients may personally prefer medication-assisted withdrawal as opposed to being on a maintenance medication. There are disadvantages to medication-assisted withdrawal. Number one, it is the treatment of a chronic condition with a short-term solution. If a patient chooses medication-assisted withdrawal, it is really important that they have significant support from a recovery community. One of the biggest risks to medication withdrawal is relapse. We know that patients are much more likely to relapse after they have been detoxed or withdrawn from opioids, and their relapse is more likely to result in overdose, which can be life-threatening for mom and baby. There is also a lack of evidence-based protocols during pregnancy for medication-assisted withdrawal. We know that pregnant women who choose medication-assisted withdrawal during pregnancy do better in long-term residential programs. There are not enough residential programs in our state, and even fewer that keep mom and babies together and even fewer that keep moms and entire families together. Another important thing to consider is there is a risk of withdrawal symptoms that are not appropriately supervised. I want to briefly talk about naltrexone medication-assisted treatment. There have been a few studies that have looked at naltrexone in pregnancy. Naltrexone is a little different from methadone and buprenorphine in that it is a opioid receptor blocker. It is administered either in a monthly injection or a daily oral pill. The monthly naltrexone injection is the only formulation that is approved for the treatment of opioid use disorder. To start naltrexone, it requires someone has a period of abstinence prior to getting their first dose of naltrexone. This abstinence period needs to be 7 to 14 days. The few studies that have looked at naltrexone in pregnancy suggested that there is very little risk of neonatal opioid withdrawal syndrome with naltrexone. Because naltrexone is an opioid blocker, it is very important that the monthly injection is stopped at 35 weeks to prepare for delivery. If a patient were to deliver while having an active naltrexone injection, it would be important to work closely with anesthesia colleagues for any anesthesia needs. So in summary, naltrexone is still experimental in pregnancy. It can likely be safely continued for someone who's already on it. It can be very helpful if someone is already stable on naltrexone, but pain management can be challenging. For any medication for opioid use disorder, there can be side effects. Some of those side effects are nausea, vomiting, constipation, headache, restless legs, and sweating. Of course, many of these are side effects of pregnancy, and the two combined can make them worse. As obstetric providers, we can really help our patients by acknowledging these potential side effects and treating them. So what about pregnancy management for a patient with opioid use disorder or substance use disorder? In the first trimester, of course, we want to get our routine prenatal labs and make sure that we are including all the recommended infectious disease screening, such as hepatitis C, hepatitis B, syphilis, and HIV testing. It's also important that we screen for tobacco or vaping, screen for perinatal mood and anxiety disorders, and then refer to addiction medicine or treatment if needed. And then at that first visit, we should also be offering naloxone for overdose prevention. In the second trimester, we need a detailed anatomy scan. And then starting at 24 weeks, we recommend monthly ultrasounds. And then it is very important to continue to support with common concerns like nausea and constipation. In the third trimester, we're continuing our serial growth scans and then repeating the hepatitis C, syphilis, and HIV screening with their third trimester labs. We only need to be doing antenatal testing if there is another condition that requires that or if the fetus is growth restricted. There's several educational components that it is important to discuss during the third trimester. This includes developing a contraceptive plan, discussing pain management options and any pain management concerns the patient might have in combination with their medications for opioid use disorder if they're on that, educating them on breastfeeding, the safety of breastfeeding, and supporting breastfeeding. It is also important to educate on pediatric protocols in your hospital for the care of the substance-exposed newborn. In the third trimester, we also recommend repeating screening for depression and anxiety. At delivery, particularly for patients on medications for opioid use disorder, one of the main concerns is pain management. For someone having a vaginal delivery, we can continue their dose of buprenorphine or methadone while they're in labor. They are candidates for regional anesthesia if that's what they desire. It's really important to avoid medications like nalbuphine and butorphanol because both of those medications can cause withdrawal for someone who has opioid use disorder. After delivery, for people who have a vaginal delivery, we want to schedule our anti-inflammatories and try to avoid opioids. For patients that have a C-section, pain control can be more challenging for someone with opioid use disorder. We should continue their buprenorphine or methadone, and then postpartum, it may be beneficial to divide their total daily dose of buprenorphine or methadone Q4 or Q6 hours. This can help take advantage of the pain-relieving properties of both buprenorphine or methadone. During the C-section, they can have regional anesthesia, and local anesthesia can be helpful around the incision. Postpartum, utilizing a multimodal analgesia plan, including NSAIDs, muscle relaxers, and medicines for nerve pain, can be very helpful in pain control. For patients on buprenorphine who are post-op, it may be helpful to choose hydromorphone as your short-acting opioid analgesic. Hydromorphone has higher affinity for the opioid receptors compared to oxycodone, which is commonly used. There is an AIM bundle framework for the care of the pregnant woman with opioid use disorder. There are some recommendations around inpatient care after delivery. This includes pain control protocols, having social work services to have a social work consult, considering behavioral health consults while inpatient. Something this also emphasizes in having warm handoffs between inpatient and outpatient teams and between obstetric and addiction medicine providers. Another initiative that can be put into place is making a plan of safe care for discharge for mom and baby. We also want to be making sure that moms have overdose education and are linked to services for addiction treatment if they are not already participating in that. Postpartum women with substance use disorder should also be offered contraceptive access according to their reproductive plans. An important element of discharge planning is ensuring that they have an appointment with their addiction medicine provider within 1 to 2 weeks after discharge. If possible, doing a warm handoff between the inpatient and outpatient providers, ensuring that plan of safe care for mom and baby is in place, and then providing education for postpartum mood and anxiety disorders, as this is a patient population that has increased for the development of both postpartum mood and anxiety disorders. Providing prescriptions for naloxone for overdose prevention, or even being able to provide patients with naloxone kits, can be very helpful to getting naloxone into the community and preventing overdose. The 4th trimester is a relatively newer concept in OBGYN, but it's the idea that the care of the pregnant and postpartum woman should not end at the 3rd trimester, but should continue in the 4th trimester, the 12 weeks after delivery. Pregnant women with substance use disorder who have now delivered can be greatly benefited from more frequent visits and touch points postpartum. A care plan that can be helpful is seeing these patients 1 to 2 weeks postpartum, 4 to 6 weeks postpartum, and then 8 to 12 weeks postpartum. So having about 3 touch points during that 4th trimester. During these visits, we can touch on postpartum mood and anxiety disorder screening, contraception, routine health screenings that may not have been done prior to pregnancy, including making sure they're up to date on vaccinations, as well as cervical cancer screening. Continuing to discuss smoking cessation, which can be especially relevant with a newborn or infant in the house. And then also, this is an excellent opportunity for linking patients to treatment for other chronic health conditions, such as getting treated for hepatitis C or further substance use disorder treatment. Because overdose is such a major contributor to maternal mortality, I think it is important to discuss naloxone and its role in overdose prevention, and to provide a little education on that. Naloxone is an opioid antagonist, so it is an opioid blocker. Once it's administered, it rapidly kicks off other opioids that are in someone's system and binding to their opioid receptors. This is how it reverses and blocks effects of opioids. There are several dosage formulations, but the most common one now that's available is 4 milligrams. And what is most accessible to patients is the nasal spray, although it does come in an injectable form. It rapidly restores breathing if someone isn't breathing, and it is in general effective for 30 to 90 minutes. However, in the age of fentanyl, patients may need multiple doses of naloxone in order to reverse an overdose. Once an overdose is reversed, it is also possible over time that they will slip back into unconsciousness. And so it is important for people to seek medical attention if an overdose has happened. Risks of naloxone administration include agitation, precipitated withdrawal, and acute lung injury from aspiration. We can easily educate our patients on how to use naloxone. We can also supplement this education with handouts or infographics on naloxone for overdose prevention. Part of that education is that if they recognize that someone has overdosed, to first call 911. It's really important that emergency professionals get there as soon as possible. If they have naloxone, they prepare to administer it, they inject it nasally, and then roll the patient to their side in order to prevent aspiration if the patient were to vomit. And the last thing is to stay with that person until emergency personnel arrive. In the OB world, when can we offer naloxone to patients? There are lots of opportunities. We can offer it at prenatal visits, especially at the first prenatal visit. We can also offer it to people who have family members with loved ones with opioid use disorder. During the delivery admission, we can offer it for patients with substance use disorder at discharge. And we can also offer it for all people that are being discharged with an opioid prescription. At postpartum visits, we can also, again, provide naloxone for our patients with substance use disorder. In summary, opioid use disorder is a significant cause of maternal mortality and morbidity, especially in our state of Tennessee. Universal screening during pregnancy for substance use disorder can improve outcomes through education and linkage to treatment. For our patients with opioid use disorder, we have effective medications. These medications can save lives and improve outcomes for our patients suffering from that condition. But what I really want you to know is that obstetric providers play an essential and important role in improving outcomes for moms affected by substance use disorder. Your work helps these moms and helps these babies, both during pregnancy and long term. Attached to this presentation are resources and article suggestions around substance use disorder and opioid use disorder during pregnancy. On the behalf of TIPQC, thank you for joining me today, and thank you for your interest in this important topic.